Hello and welcome back to our HARC 5 question series. Today we're talking with Professor Greg Maynard, who is the Director of the University of California, San Diego Center for Innovation and Improvement Science.
Well, the studies that keep coming out always show that it's much lower than you would expect. 50–60% of the time maybe we get care correct. We deliver all the best practices that are supposed to be delivered. The reasons for that are many. We have super subspecialization. We have, instead of focusing on just one problem when the patients come into the hospital, they have 30 or 40 things that we're supposed to touch base on with quality measures. We have an explosion of new literature that makes it very difficult for everyone to keep up on that. And nobody's admitted for things like DVT prophylaxis. It's just one other thing to do. And situations change very dynamically in the hospital. So it's difficult to do everything right and deliver the best care 100% of the time. They can provide prompts at the point of care when you don't have computerized physician order entry yet in most of your hospitals, but soon you will. And as you order medications, you're getting cues about what the best medication might be right at the point of care. So you build clinical decision support in at the point of ordering or at the point of care as a nurse admits a patient. There's prompts and reminders of the protocol guidance to follow, and that can be very helpful. Then you can use reminders that pop up. Those have to be used very sparingly because they can interrupt workflow. And then there's communication routing. There's ways to share information across multiple disciplines and from nurse to doctor. Now, not all the electronic medical records are necessarily built to do that, so they require customization sometime. They can be a great way to capture data. So you have to build and design those measures in from the start. You have to define your operational definitions and try to integrate that measurement right into the orders, right into the documentation so that you can pull that data out later, so that you can get month-to-month data. And then finally, you need some presentation of data so that it makes sense to the physician or the nurse. So you're able to generate month-to-month reports, you're able to do some research around it, you're able to do technical vigilance, if you will, to find out if people are struggling with their care. It helps communicate, it helps route things efficiently. I can tell you that no one has built the ideal system at this point, and that people keep trying to tailor and get all these ideal things into the record. There's many other functionalities that we wish they would have. For example, if you're in hospital A, you would like to immediately get the results from hospital B, or from the clinic, you'd like to allow the patient access to those records when pertinent to do so. And to be honest, most of the vendors for the electronic medical records, out of the box, they often lack most of this functionality. You have to keep tailoring it and keep working on it. And the more you can centralize that, the better, I think, because it's very labor intensive and costly, and every hospital can't replicate it. It's impossible. Well, first you have to define what the right care is. You have to define it. You have to focus on what are the most important things you're doing. You have to prioritize. And then you have to decide, how will I know if the best care is being delivered or not? How will I define best care operationally so that I can actually measure it? Then you build that guidance into order sets, and you build it so that into the documentation so that you can pull it out as a discrete variable, as opposed to writing 5 sentences of text that you can't really pull information out of. So it's again, it takes forethought because you have to decide up front what's important, and you have to make sure that the operational definitions are there and that people are using those definitions in their documentation, and that the nurse is using the same language as the physician, so that you can pull that data together. Well, first of all, you've got a big advantage. You've got most of your hospitals and systems are on one electronic medical record. Now, you might not think it's the best one, and that can be argued, but it's important to have that consistency. It makes it easier to share information, makes it easier to build common tools. Having said that, there's many, many ways to go wrong, and you're still at the phase where most of your medications are not available electronically. A lot of your reports are not common, and you're just adding certain data elements now into your electronic medical record that are not there. So I think it's a great opportunity to, again, define your priorities for quality and safety and build your record around those quality and safety issues, and build common clinical decision support tools into order sets that target 80% of the patients. Don't try to target 100% of them. And then carve out the specialties. Don't let perfect be the enemy of good. And try to standardize these things so that you're building the measurement in as well as the clinical decision support at the same time as an integrated system.